All right. Hello, everyone. Thank you so much for coming. Sorry for the slight delay. Super excited to have all of you here. This is our inaugural event. This semester, we're hoping to hold a series of workshops that address the intersection of race and health. And for this one, we have some wonderful speakers. Professor Miriam Rich, Dr. Emily Wang, and Mr. Tino Negron are joining us today. So I'm Jeremy Ottridge. I'm one of the student leaders for STEM and Health Equity Advocates. And I'm going to be one of the student facilitators for our conversation today. So we have some time set aside at the end for questions, but if you're interested in continuing this conversation, we have a follow-up workshop tomorrow with some additional speakers. And it's also at 5 p.m. and you can find the link on our Facebook.
So hi, everybody. My name is Steven, and I will also be one of your student facilitators for today. I am one of the co-presidents of the Black Queer Health Students at Yale, otherwise known as BPHY. And before we fully introduce the speakers, we want to let you know about some of the work that SHEA and BPHY are doing around Yale. In addition to hosting these different workshops, SHEA is calling for the expansion of the HSHM department to accommodate more workshops and classes to educate students about the intersections of both health and race. If you want to support this work, please sign and share the petition linked in the chat, and it can also be found on their Facebook page. And the Black Queer Health Students at Yale, or BPHY, we are a student organization dedicated to empowering students across the African diaspora interested in pursuing a career.
Yeah, we have an amazing panel of experts on mass incarceration and its impact on well-being with us today. So first is Dr. Emily Wang, the director of Yale's new SHEA Center. Did I say that right? Awesome. Center for Health Justice and co-founder of the Transitions Clinic, both dedicated to improving the health of individuals and communities affected by incarceration. She is also a practicing physician and an associate professor of general medicine at the Yale School of Medicine. Her research focuses on how incarceration affects health outcomes and contributes to health disparities. Mr. Tino Negron is an outreach specialist for the Health Justice Lab's Justice Study, focused on cardiovascular disease among justice-involved individuals. And Professor Miriam Rich, a lecturer in HSHM at Yale College and Yale School of Medicine. Her research focuses on the social and political concepts of health and bodies within historical systems of race, gender, and citizenship. She teaches courses about the history of health and incarceration, reproductive health and medicine, and the history of public health, race, and citizenship in the United States.
Sorry about that, guys. If you guys have any questions during the panel today, please send them to either myself or Jeremy, or just put them in the chat so they can be included in the later Q&A. To start a discussion, Professor Rich has prepared a brief presentation to orient us on the history of mass incarceration and the role that medicine has played within that history. So I'll pass it off to Professor Miriam Rich.
All right, thank you so much to Stephen and Jeremy and all the amazing student organizers of this event. I'm really excited to be here. So I'm gonna go ahead and share my screen. Great. So I'm going to give a brief introduction to the historical contexts of mass incarceration and health. I'm going to start by briefly defining and discussing the origins of mass incarceration, and then provide an introduction to the entangled histories of health, medicine, and incarceration. So mass incarceration refers to a system in which a huge proportion of the population is confined in carceral institutions like jails, prisons, and immigration detention centers. Today, there are about 2.3 million incarcerated people in the US, and many millions more subject to parole and probation systems. For some perspective, that means that per capita, the US locks up more people than any other nation. In the US, mass incarceration is characterized by extreme racial disparities, disproportionately affecting Black, Latinx, and Indigenous communities. For example, Bureau of Justice statistics show that Black people are imprisoned at a rate that is more than 5 times that of white people. In the early 1970s, the prison population was a small fraction of what it is today. And we can trace soaring rates of incarceration back to policies implemented in the late 1960s, 1970s, and 1980s, including the war on drugs, which heavily invested resources in policing and punitive programs and diverted resources away from non-punitive social services and programs. It's important to understand that these policies were racially discriminatory from the start. They emerged in backlash to civil rights movements and protests for racial equality, and disproportionately targeted low-income, predominantly Black and Brown communities at every level, from disproportionate policing activity and surveillance in those communities to disparities in sentencing guidelines. Now, some scholars have traced the historical origins of mass incarceration back even further. The legal scholar Michelle Alexander famously characterized mass incarceration as the new Jim Crow, arguing that mass incarceration today sustains a system of legalized racial discrimination that functions in a manner very similar to Jim Crow, referring to the set of laws enacted to enforce racial discrimination in the late 19th and early 20th century South. Other scholars have pointed out continuities with historical anti-Black carceral institutions, institutions of confinement, including slavery, and the penal system of convict leasing and forced labor that arose after the abolition of slavery. Now, from the start, the histories of health and incarceration have been linked. And this has been true since the inception of the modern carceral system in the United States. The early 19th century saw the rise of prisons as central institutions of punishment in the United States. And physicians such as Benjamin Rush played a major role in conceptualizing, overseeing, and validating these institutions, which were imagined as therapeutic penitentiaries that were supposed to reform both the physical and moral health of those inside. These institutions relied heavily on solitary confinement as their mode of rehabilitation. But from the start, observers noted that these supposedly rehabilitative practices caused grave health harms. So this is a report made in the mid-1820s, so almost 200 years ago, by the physician of the New York State Prison at Auburn, describing the health effects of solitary confinement. There's a long quote here, but this physician described how those held in solitary confinement were especially vulnerable to respiratory illnesses, physical deterioration, and death, and that this was true even after they were released from confinement. The physician also reported that a number became insane while in confinement, and that others physically injured themselves in their desperation to escape. So we see that already in the 1820s, observers were describing the terrible effects of incarceration on physical and mental health. There were also extreme health harms associated with the penal system of convict leasing and forced labor, which was a system that served primarily to incarcerate Black people in the decades after the abolition of slavery. For instance, the historian Talitha LaFloria describes what she calls the medical terror that was inflicted on Black women imprisoned in Georgia's convict lease system, writing that these women suffered both from severe medical neglect and also from being forcibly subjected to intrusive medical procedures by unskilled practitioners. Moving into the 20th and 21st century, the medical profession has historically been complicit in many health harms of incarceration. There is a long history of incarcerated people being subjected to both medical abuse and medical neglect. This history includes involuntary and coercive sterilizations performed by prison physicians in the early and mid-20th century, and in some instances in the 21st century. It includes exploitative practices of medical experimentation on imprisoned populations, and it also includes lack of adequate prison health care and histories of HIV/AIDS, of mental health, and reproductive health care. Now, the problem of grossly inadequate prison health care received increasing attention in a series of exposés, reviews, and lawsuits that intensified in the 1970s. The most influential of the lawsuits resulted in the landmark Supreme Court ruling, Estelle versus Gamble. Now, this case was a big deal because it established the government's obligation to provide medical care for those whom it is punishing by incarceration. In other words, it established a right to health care inside of jails and prisons. However, there were and are serious limitations to this ruling. Estelle versus Gamble set the standard of deliberate indifference, which means someone who suffers medical harm or neglect needs to show not just that they were injured, but that their treatment was knowing and intentional. The ruling also does not address the health needs of people after incarceration. Just want to end this brief overview on a forward-looking note by discussing the role of health in demands for structural change. Now, historically, groups of incarcerated people have protested the health harms of incarceration as a way to demand change and justice. For instance, during the Attica prison uprising of 1971, the Attica Liberation Faction presented a list of 27 demands to prison and state officials regarding the conditions of their imprisonment. And one of their very top demands related to medical care. They wrote, "The Attica Prison Hospital is totally inadequate, understaffed, and prejudiced. There are numerous mistakes made. Many times improper and erroneous medication is given by untrained personnel." They demanded specific changes in medical staff and medical policy and procedure, framing the centrality of health in the harms of the prison system. So clearly there is a lot more to say on all of these topics, but I hope that this brief historical overview can set the stage for a robust discussion now of the effects of incarceration on health in the present day.
Awesome, thank you so much. We're now going to move into our guided question discussion section, where we're going to ask a couple of questions and allow the panelists to discuss and go where the conversation takes them. So this first question is very much a follow-up to Professor Rich's PowerPoint, and I wanted to direct it first to Dr. Wang, wondering what this form of healthcare looks like presently in the prison system, what challenges it needs to and doesn't address, as well as how it contributes to the experiences and illnesses of incarceration.
I'm taking notes just to kind of make sure that I cover kind of these three buckets of, the kind of the current practice of healthcare behind bars. And in particular, I mean, we are living through a novel SARS-CoV-2 pandemic. And so what that feels like inside, as well as the challenges and then the experiences of those that are incarcerated and released. And, one of the things I'll just also acknowledge is that Miriam and Tino, I mean, none more expert than Tino here. So I may leave the question about kind of the experiences of what it feels like to be a person, incarcerated patients inside and then returning home for Tino and then others I also do see. Professor Baskin-Somers on here too. So there's many experts here. What I will say is this. I mean, I think I just appreciate the introduction. I've been caring for, now over a decade of almost thousands of people that have come home from correctional facilities, both jails and prisons, both here in Connecticut and then in San Francisco, and have started this national network of programs that care explicitly at the intersection where the healthcare system really fails people that move in and out of prison. So, a correctional system, a healthcare system behind bars where there is a constitutional guarantee, and then one in the community where there is no or had not been any constitutional guarantees to healthcare until the Affordable Care Act. And so, in all ways, when I think about kind of the practice of medicine, and especially for people that are impacted by incarceration, this is a second tier, third tier, fourth tier healthcare system that exists within our country, over which almost no one really truly oversees. And so, I think a clear point is that we have this constitutional guarantee behind bars, and then this transition point for when people return home that's highly risky. So a seminal study came out in 2007 showing that and I can tag these citations later on the side if people are interested, that there's about a 12 times increased risk of dying in the 2 weeks, 6 weeks, 8 weeks, and then on through a year post-release from a correctional facility. And the reasons for dying in this study, this is a large-scale study done out of Washington State, are those that are highly preventable. So overdose deaths, heart disease, cancer, suicide, for patients with depression, and then even homicide. And so largely deaths that are preventable and really happen at the intersections when people are being released from correctional facilities and then come home into the communities. And so when I think about this, and when I think about the healthcare behind bars and then in the community, it's this hole, it's this gap in care that's a real kind of big issue. The second place that I would say is that, and I'm happy to speak to that, kind of the problems of that interstitium. The second thing I would say is that, in spite of a constitutional guarantee behind bars, the whole practice of medicine is really different behind bars. And so I wonder, some of you aren't on video and I'm not going to ask you to come out, but for those that are, how many of y'all have stepped foot behind bars? Like gone in before? Okay. Well, let me advance through my screens to see if anyone. Okay, so usually I bring some photos, and I bet Lisa tomorrow will bring some photos, or I'll tell her to bring some, just so that you guys can have a visual a kind of memory of what it may feel like to be a patient or a healthcare provider behind bars. There is this constitutional guarantee, but the whole way that the healthcare system is designed is entirely different. And the things that I think are important to highlight are that many people, adults that are incarcerated, first access the healthcare system when they're in behind bars, in a jail or prison, because this constitutional guarantee. As adults, they've never, they're young, healthy, they didn't kind of ever see the need of the doctor, or they're uninsured, can't afford it. And so their whole experience of kind of what the healthcare system feels like is behind bars. And so many people are first screened for chronic conditions, screened for hepatitis C, screened for HIV while they're incarcerated, are newly diagnosed. And these are kinds of, like it or not, gains to the system, gains to the patient. You can kind of understand more about your chronic health conditions. And then also the whole way that these chronic conditions are managed is entirely different. So it's a pretty passive healthcare system. You never have to call the doctor. You can't see call the doctor up. If you have a pressing health need, you have to kind of notify, sometimes in certain systems, this isn't the way in Connecticut, have to notify a correctional officer. The correctional officer then notifies the nurse. The nurse, if they think that it's a health necessity, then notifies the physician, and then you get called in. Someone saw me. That's okay. You sometimes you have to pay $3 copayment in Connecticut, and so that's equivalent to 4 days work for people inside. And so there's all these different sorts of barriers to accessing healthcare. And then because you don't make a pharmacy line, you don't kind of take your medications yourself. You get called up in the middle of the day. Early in the day, and like you have to make a med line to actually see the nurse, see the correction officer that administers the medication. And so adherence is kind of almost 100%, but it's very, very passive. And so in all these ways, kind of the way that we deliver healthcare is totally different inside than what we expect for when people return home. And what it means then, and then the last bit that I would say is that how healthcare is financed behind bars is, and also how it's overseen behind bars is totally different than how it is in the community. And so in the community, we have kind of federal agencies that oversee the quality of care. And if the quality is good enough, then you get cash to kind of get compensated for your care. That's how you get paid for Medicare and Medicaid, et cetera. Behind bars, there's no one overseeing the delivery of care. And so with COVID, many of y'all may know, but 90 out of the top 100 cluster outbreaks in our country are within our prisons and jails. Prisons and jails don't have the resources right now to actually have enough tests, enough swabs. Y'all have probably seen it on the news, masks, PPEs, even sanitary supplies. There just weren't the resources to contain kind of this mass epidemic. And so in so many ways, our institutions and structures, both in the community as well as in prison, really constrain the health, really are kind of deeply oppressive of the health and well-being of those who are incarcerated and move home. I don't know, Tino, I'm looking at you in my upper left-hand corner, if you have anything else to add to that.
Well, absolutely. First and foremost, Dr. Wang, thank you for allowing me to be a part of this study and this information that needs to be addressed. But I'm going to briefly help the people in attendance to understand by helping them walk down the corridor. Dr. Wang actually mentioned something about going to a med line. There's also, we're talking disparity, we're talking disproportionate, we're actually talking a lack of communication. I am formerly incarcerated. I'm just recently released in the last 20 months. I've served a substantial amount of time, and I'll put the number out there. I served 30 years of incarceration. I spent 10 years in solitary confinement. And it just so happens that I'm very familiar with this corridor. We're able to walk down. I'm not talking about standing off your feet. I'm talking about sitting on a bunk and actually trying to get to these type of physicians. And the disproportionate part, the disparity that we're actually talking about, just ain't based on color. It's based on other people that are not there available. So there's a number. There's approximately 2 to 3 physicians in a facility that houses between 750 and 1,200. So we're dealing with this thing that deals with whether or not there's being misdiagnosed, undiagnosed, and you have to use a form of a piece of paper that they call a request. And then that request is being sent to a small medical unit. The staff there is understaffed. So there's approximately 4 people that are working there, whether they're a staff member, the Department of Correction employee, and or a medical nurse that's working 2 shifts. A document comes under the door. Through that documentation, the documentation is either sent because the individual is trying to see a doctor or he's trying to get out of his cell based on his psychological aspect of trying to understand that he's actually incarcerated. The sad note is that I am one of those individuals that was released into the community where you diagnose one thing and you find out after getting this access to healthcare that Dr. Wang's talking about, and previously that Dr. Rich had mentioned when you start talking about Attica and places like that in the early 70s. This is a population that's being undiagnosed. They're a population that's coming back into our communities where they never had the proper health care. So this is the access that they're able to obtain out here in this community. As far as the medications that are being provided for all different type of diagnoses. So, this is the field that we're dealing with. Like I said, when we're talking about disparity and being disproportionate, it's really a lack of communication, but most importantly, it's a lack of funding that's providing these doctors to provide this healthcare inside the Department of Correction, whether you want to call it a penitentiary, an institution, and or just being incarcerated. So I think that's a little bit of information, but I will give a briefing on when I'm able to discuss where I come from, where I'm at today, and how I got here. So I thank everyone for being on the call and listening to this information.
All right, so thank you guys. Thank you both for your answers. I'd like to transition the conversation now towards what life is like after incarceration. So the question is, how is healthcare outside of prison set up to treat formerly incarcerated individuals? And what does access to healthcare and prioritizing health look like for those who are formerly incarcerated?
So, Jeremy, thank you again. The formerly incarcerated component is allowing those that are incarcerated come back into the community, whether they're on some form of supervision, and the majority of that population is released back into our community, where they're sent to either a halfway house, a residential housing, where the medications that are sent from the inside of the department are out into the community. But like Dr. Wang had mentioned, there's not as much supervision over providing this medication. So hence where, the Yale Transitions Clinic provides this access to health by having a community health worker and or outreach specialist like myself that's able to go into these halfway houses and get into a discussion with those that are formerly incarcerated, just as involved in the community, and the access to health through Yale Transition Clinic Health Justice Lab actually gives them an opportunity to find out whether they have some of these conditions that consist of cardiovascular disease that deals with this thing of high blood pressure, high cholesterol, diabetes, and or obesity. Some of these young men and women that come back into our community, they have yet to find out whether they have one of these components to fit the criteria where they actually are provided with a primary health doctor. And then when they're able to do that is when we're able to actually help them get into other fields of mental health issues that are developed over the course of their incarceration. So by coming back into the community, me and a couple of our community health workers go into these residencies, we're able to have a direct conversation where they start to feel comfortable because now they're speaking to someone that looks like them, sounds like them, and actually has been through something similar that they're continuing to go through as we speak.
I'll add to that, which is just to say, one of the reasons that we started kind of transitions clinic programs almost a decade ago is because of this hole that I mentioned, right? There's a high risk of dying immediately post-release, and then subsequent studies have shown preventable hospitalizations, even amputations from diabetes, kind of that could be prevented right in that hole, are at higher risk right at the point of release. And so when these programs don't exist, though, there aren't the kind of thing to think about is that again, if you were incarcerated, let's say the majority of your life, or you've never seen a healthcare provider, and then you get diagnosed with your diabetes, right, while you're inside, you come home, and for most folks, like when you're coming home, the kind of biggest goals that you're focused on are where you're going to live, how are you going to get your next meal, where's your ID, like healthcare maybe is part of your mind, but like over the years, I found that it isn't, even though it soon will catch up to you. Like where you're really going to worried about is like where you're going to stay, how are you going to get some cash in your pocket, how are you going to eat, right? And so our system creates all sorts of barriers to kind of putting health, in the fore of people's minds. And so, as y'all know, we had probably, I think, one of the most profound criminal justice reform acts passed, which is the expansion of Medicaid through the Affordable Care Act. And so what it meant is that now like 32 plus states now have expanded Medicaid. And so people that are returning home from prisons and jails actually qualify for some health insurance. Now it's the health insurance that, just distinguishing Medicaid from Medicare for kind of low income adults, but it is a form of health insurance that then pays for primary care, for substance use treatment, for mental health treatment, as well as your meds, right? And so that's transformative. The second piece that I would say is that, most folks, newly accessing healthcare actually don't know how to use it, right? Like they've never actually had to make a primary care doctor appointment. Again, it's not priority. And so a lot of what ends up happening is that even in states that have expanded Medicaid, while insurance rates have gone up, they haven't found that people engage in healthcare, substance use treatment, or mental health treatment at higher rates following release. So these are big national studies that have looked at justice-involved populations and found that it doesn't move the needle. Insurance is necessary, but it isn't sufficient for getting people into care. And so that's where people like Tino, like Jerry, who maybe I'll meet tomorrow, kind of play a role, which is the best studies where the evidence base is strongest is showing that when people have histories of incarceration are met by other people with histories of incarceration to enter a health system that is overtly and discriminatory at times against certain sorts of patients, have kind of, again, you can imagine what's happened in prison and jails. Many people feel mistrustful of the healthcare system. Why the hell are they going to, trust a new doctor? You need someone that you can trust to say, these folks are on the up and up. Primary care is something that we think is valuable and will help you do all the other things that are number 1, 2, and 3 priority, and will also get you to learn how to use your insulin needle for your diabetes. And so these are kind of some of the holes, again, that programs like Transitions attend to. It doesn't attend to the larger institutional policy and structural issues that are profound barriers for people that come home. I mean, we have innumerable collateral consequences that prevent people from meeting kind of, again, their own goals, needs for food, like food stamp bans exist in 10 southern states, housing bans for people with drug felonies. And so again, this is one place where thinking about these transitions, thinking about the holes, thinking about how people can come home into systems that are not inviting. And especially I look around, many of you are future health professionals. I mean, this is what we have to look at when we talk about kind of, if you're fired and motivated about defunding police and thinking about how we restructure and reorganize our social services to support and better be inclusive of a social contract that includes people with histories of incarceration, how we have to manage our health systems is a big piece of how we decarcerate this country.
And Jeremy, real quick, I would like to add to what Dr. Wang had mentioned. If we're looking at the study clearly states that over 90% of those that are incarcerated, I believe it's at 92 to 95%, are being sent back into our communities. What type of population do we want to come back into our communities for those that are from this faculty that eventually will possibly be doctors in this field? That's the component what Dr. Wang was just mentioning, to actually intervene now while we can, to those that are coming back into the community, to remind them that it's not the self-preservation aspect of just coming back into our community, looking for some form of employment, food, housing, or shelter, but actually having access to their health care. Because without their health care, who sees and be concerned about the employment aspect of all this, the food, the shelter, and or the clothing? So this gives us an opportunity now to go into these facilities and help fund these programs that can actually provide this new concept that's really not that new. But when you're dealing with inside the Department of Correction, they're under the impression that the biggest component of coming back into the community that they're being taught is to be employed, to have some form of housing, and the component that's actually missing is actually their health care. Because like I mentioned earlier, Jeremy, a lot of these folk are either undiagnosed or not diagnosed at all.
Yeah, that's an awesome point, Tino. Thank you guys for discussing this so thoroughly. I'd like to kind of follow this up and also maybe put it in history a little bit more about kind of think about where we go from here. About, we're talking about how there's a disconnect between being incarcerated and coming back, and being formally incarcerated, and the resources available and the role that health professionals play in that disparity. And as you're talking about, Tino, in those the disproportionate access in prison and outside. So I was wondering if we could talk a little bit about, what do we do with the system we have structurally with mass incarceration, and how can doctors, a lot of people's future health professionals think about their own involvement, their own role in this, and how can they more positively contribute to ending this system and finding a better solution.
Well, I believe that the biggest component that transitions clinic through the Yale healthcare has actually been to tap into this issue and this concern is they allow those that's been formerly incarcerated to become more involved and to work collaboratively to have a contribution with these folk, because these folk are the type of individuals, whether male or female, that are coming back into our community. They're coming back into the community broken, fractured, and confused. So when they have someone that looks like them, as I mentioned earlier, sounds like them, sometimes dresses just like them, it helps them feel more comfortable about having a direct dialogue and being able to get into these issues and concerns that are really underlining. Dr. Wang mentioned earlier about the substance abuse issues that are very high inside the Department of Correction, that were there previously before getting inside the Department of Correction. And if it's not addressed on their way outside the Department of Correction, it really is only a problem when that problem lands in your yard. We're trying to prevent that problem from coming back into our community. So by us collaborating together and by actually providing this information, some folk like to talk about arguing. Let's make an argument. I don't think that's the right way of handling the situation. I think the right way of handling the situation is to provide evidence-based issues and concerns, how this data, how the statistic, and how these numbers work to actually help these folk that are coming back into our community.
Oh, and Professor Rich, are you able to talk a little bit about kind of the history of the establishment of the system and how it's been targeted or it's been created without awareness for this need, and that's created this gap?
Yeah, absolutely. And I think, as I mentioned earlier, looking back to when the system that has become mass incarceration first arose, looking at the confluence of circumstances that set that up to happen, I think it's really important to understand that mass incarceration is not the only way to structure society, that jails and prisons are not the only places to provide health care that is constitutionally guaranteed. One of the big lessons, I think, from the history of the rise of mass incarceration in the late 60s and the 70s and the 80s is the investment in, the choice to invest in policing and in punitive agencies, and the choice to disinvest from non-punitive social services, agencies, community resources. And I think that at that moment in time, a different choice could have been made, but also at this moment in time, different choices can be made.
Thank you for your answer, Professor Rich. So lastly, to wrap up this conversation for today, we do have some audience questions that we wanted to ask. The first one is, how likely is abolition to happen, and what systems need to be, what system or infrastructure needs to be built for that needs to be built to support abolition?
I'll start off and just respond to this, because I've been thinking a little bit more about this lately, and I take kind of some of this, my own thinking around this, mostly around historians, of talking to historians. And so, just to draw a parallel, from kind of the abolition of slavery, like it's a moment, right? And like a real key component to that is that that's a moment within history that we have not seen the full articulation of what that moment should have been. Reconstruction was for just a little bit over a decade. And so, when we talk about kind of abolition, and I'm assuming what you mean is the abolition of a prison or jail system or a carceral system. I'm a primary care doctor, I'm a physician and a researcher, a Yale professor. And within my role as a doctor, where I see it is, what does kind of a society where prisons and jails doesn't exist look like? And what is my role as a physician in that? And so, I think it's the easier stuff is to talk about like the day of abolition, like what it is, and we demand it, we want a shifting of budgets. The really kind of deep stuff that I think, like I look around my colleagues and health system providers, is what does that reconstruction? How do you create an interstitium that actually supports the needs of everyone, that supports the health and health needs, the well-being of all communities? And in doing that, you have to really, really interrogate my own values, the values of my profession, and what it is that my health system is doing right here, right now, what it is that my university does right here and right now to not support that. And that to me is the more profound question as a healthcare provider. And I would say as, aspiring health folks that are interested in the health professions, to me, that's the real kind of question that, there are more and more healthcare providers that are interested in these issues, but it's still really taboo. It seems so outside of the healthcare system. And I'll share one anecdote is that I've been involved, some more intimately and some more peripherally, on kind of closing Rikers, right? So a profound expression of what abolition looks like, the closing of an old, terribly oppressive jail in New York City and what it means. And I can also tell you that, like the population has gone down from 10,000 to almost 5,000 now. And, probably, COVID's gone down and it's been mostly passive closure. It's like not an actual active decarceration, but there are probably 1,000 people inside that it's almost impossible to imagine where they would go, where they would live, what healthcare facility could take them. They're so institutionalized, there's no place that they actually can live. And that's the real kind of, I think the phrase is like where the rubber meets the road. Like our healthcare system isn't structured for those people. Our housing system isn't structured that. Our laws don't permit them a place to live. And so until we kind of can grapple with what we're doing on the inside, like I have to just own my role within the healthcare system. And so to really push for the systems that exist in the community that can create the social safety net and a new social contract for people that have been incarcerated, that to me is like the real kind of where what motivates and energizes me.
Stephen, it was not that long ago. This is heartfelt for me, man. It wasn't that long ago where I've heard some folk that were coming inside the Department of Correction. It was probably about 4 years ago, and they created a small unit for the youth inside one of the correctional facilities here in this state. Now you have a commissioner that was just named commissioner that's worked for the department for over 30 years. I've probably known him since he started his employment through that occupation. There's a lot of hope. There's a lot of hope in a hopeless situation inside the Department of Corrections today. And the reason why is because them young men, whether they're 21 or whether they're 61 or 81, they're hearing about the work that's being done through Yale's faculty at Yale University. I've heard myself when there was a cell built inside the university so we can get a more clearer and familiar view on what it looks like for someone to be locked up. The sad note is I wear many hats today. I not only work for Yale University, I help out in the reentry field, I help out the US government. I fly all over the country on a bird with windows that they call airplanes today. And it gives me a clear perspective on what's going on in Biloxi, what's going on in Mississippi. And I've been able to come back and go. I'm actually been going back inside the Department of Correction. In the 20 months that I've been out, approximately 8 months after I got out, I was already back inside the Department of Correction and reminding them that there's people in this community that's not just fighting for them, because that's not the proper definition. I believe is explaining to the public that they're no longer a public issue if, as Dr. Wang had just mentioned, if we have a place to send them to. Because even during this pandemic, epidemic with this COVID issue and concern, there was a lot of men that were ready to come home, but where were they going to be sent to? There's a small version of this story where one of these young men was going to go back to live with his mother, and he was probably 50, so you could just imagine how old she was, but based on her housing and her receiving some state benefits, he would have not been able to go there. So back to the 90% that's coming back out into our society, where are they going to? And then it becomes a problem if they come out and can't function under these circumstances because they didn't have the proper care, they commit a crime. And it becomes a serious problem when it happens close to your home. So to clean that up, I would have to say, let's revisit these conversations and get the people that are in the room that have a certain way of giving a description to the people that are housing these people. But most importantly, where do we send these folk back to when they get here? So let's argue to the point, not just healthcare, but to housing, employment, and food. Because if they don't have that, then their crime's eventually going to be committed. So I think it's important that we start talking to these agencies that can fund these places where these young men and women have a home to come home to.
Definitely, and thank you both for your answers. It's so true that social infrastructure really needs to be built in this larger conversation about decarceration. How are we supporting formerly incarcerated individuals at large? That is so important. And thank you guys. So this next question has to do about the psychological impacts about being incarcerated. So the question is how mental health is addressed specifically within prisons and whether or not the health system is equipped to provide mental health care to those who have been formerly incarcerated.
Well, the psychological aspect is the individual actually wanting or feeling necessary to go and see someone. I heard the word taboo. I believe it was from Dr. Wang probably 5 minutes ago. You know, it's taboo for someone to want to come back into the community and feel as though, because now when it's documented that this individual has some form of issue or concern, he can't find no form of employment. And if he's seeking some type of disability because of the time he spent while he or she was incarcerated, it's noted inside some type of pieces of document, and it doesn't allow him to work. It doesn't allow him to function. And hence where this thing leads back into some form of substance abuse, whether it's alcohol and or whatever. But I think the biggest component is for some people in faculty, on staff, in the university to take an interest and want to go in and have this discussion with these young men and these women and provide them with those services. This is not just a mere conversation, because if it's just a conversation, we're still going to have a problem. I think this is an opportunity for us, through your discussion, Stephen, about the question that was asked, for some people in the room to raise their hand that have some form of degree, whether it's a doctorate, a master's, or an associate, to say, you know what, I specialize in providing this information to not only uplift this type of population, but actually enhance them. So when they do come home, we don't deal with that number. And there's some numbers. The number 78.6, recidivism in the first 3 years after release is 78.6. That's 8 out of 10 in the first 3 years. You can look that up through the Bureau of Justice. Through research, we come to find out that people can change. They just need the proper services to help them do so.
I'll just follow that up by saying, you know, I'm also cognizant that Ariel's on here too, who is really an expert in this. So what I will say is kind of, again, what you might imagine is treatment, you know, kind of mental health treatment broadly, and thinking about kind of treatment for normal conditions, really more, not normal, prevalent conditions like depression, anxiety, even post-traumatic stress disorder aren't treated in the same ways as they are kind of behind bars than they are in the community. And there is kind of also the taboo of kind of being identified as having a mental health condition while incarcerated, compared with, differences that may exist in the community that are pretty profound. I mean, I do think one piece that, we would be remiss in not mentioning is, because of kind of the extreme conditions of confinement in the US, including solitary confinement, which Tino discussed, but also just exposure to violence, social isolation, especially now with and physical distancing with COVID, real concerns about kind of poor healthcare and how that even is a source of trauma. Those sorts of mental health conditions, the ones that we would imagine are true, exist, are rarely treated, right? They're rarely discussed, they're rarely acknowledged, and they're rarely acknowledged in the community health system. Because we don't ask about having been incarcerated. Very few healthcare providers actually know that, to ask about it, when to ask about it, why to ask about it. And so in so many ways, the system itself creates trauma and then creates kind of either augments or creates kind of new conditions that are tied to this trauma. And none of that really is being addressed. One other thing I will mention is that also there's partners, kids that are left behind, and that are in the community. And these are other ways that the system replicates and creates trauma, I think, for those that are in the community and tied to those that are incarcerated.
Thank you both for your answers. And lastly, to wrap up in thinking about future direction and really, I guess, the call to action that's necessary to bring change to fruition, how can students get more involved with efforts like Transitions Clinic and really be involved in the work and actively be active in this field?
Well, I think I'm going to just tail on to something that Tino said, is that I, especially in my work with medical students, like really appreciate the energies and the optimism and the kind of deep commitment that students have for social justice. And also to know that while this is your home and your community, there are people that have lived here for longer, know the history, know the community ties, know the kind of institutional structures, people like Tino that really are the leaders of what we ought to be doing. And so many students and faculty come in with energies of like, I've got an idea and I've got to fix it, and here we are, let's do it. And I would say that with humility, as I've been reminded over and over in my career, is to pipe down, ears open, listen up, and really kind of support the work of leaders that exist here in New Haven, leaders that have been formerly incarcerated, currently incarcerated individuals, that we listen to what the needs are and then use our privilege, power, kind of, et cetera, to then articulate and support those visions. I mean, I would say that there's one single thing that I would lead with is that there's a lot to be done. I look at you guys and there's just so many of you. The road is long. Like I think about kind of what it is that we have to do to decarcerate our nation, and it's not gonna be my generation. I don't even think it's gonna be my kids' generation, and I'm hopeful that it's in 3, but it means that it's an all hands on deck. And it's something that this isn't new. This has been around for generations, and we're going to need new energies and new ideas, but really listening to folks that have been here and have been doing this work. I also just land on where Miriam started, where turning to history, like we are just in the urgency of the current moment. You think we got to hurry up and rustle up and do what it is that we need to do. And these are not new problems. I mean, COVID's new. That this, like structural racism, the oppression of the carceral system, isn't new.
Dr. Wang, you mentioned turning to history, so I was wondering if Professor Rich could perhaps speak more about that and thinking about these current issues and what we can do.
Yeah, absolutely. And I really appreciate sort of how eloquently Emily has sort of set forth the importance of understanding history. I think, it's important to see the present moment, not as something that is the way it is and has always been this way, but as something that is the product of particular social, political, economic histories. Understanding those histories, understanding the forces, the confluence of institutions and people that produce the present moment, I think is really important work in being able to build a future, build different institutions with the specificity that Emily and Tino were talking about. That in thinking about dismantling, decarcerating one form of institution, we really have to do the work of thinking about, okay, on the ground, what does it look like to build different kinds of institutions, different kinds of ways of living? And I think history is an invaluable resource to understanding and grounding those types of projects for the future.
Tino, do you have any closing remarks that you'd like to give us to the group?
Absolutely. First and foremost, I would like to thank the rest of the panelists, especially the information that Dr. Rich provided and the insight that Dr. Emily Wang provided to the rest of the students here, because I've always looked at our world as it's just all a process. We're dealing with students that are eventually going to become doctors, they're going to become lawyers, they're going to become prosecutors. And you start to get more familiarize yourselves with what looks like, can people actually change? Can people, do everyone need some form of help? What does hope look like? But the important thing is that after the discussion, where do we go? My closing arguments will be, where do we go after this discussion? Is this just a discussion, or is just more to this discussion that's yet to occur? And I think the only way for us to make that, the only way for us to make that happen, the only way for us to make that happen is to us, in order to make a contribution, we must continue to collaborate. And I think that's an issue in our community today. There is no collaboration amongst the people that Emily talked about, the people that look just like you. They just haven't had an opportunity to share with you what they would do if they was in position. The only way for us to come into position and to make some change is to us to come together. So if there's anything that I could further do to help the students become more clear-minded, I'm here, I'm a part of this faculty, I'm a part of this community. If there's anything that I can ever do to help clear up, clean up, and to help somebody else understand that we all matter, we all matter, and again, then we have a way to look at our future in a brighter place. Thank you again for allowing me to be a part of this.
Awesome. Thank you all for your remarks. But before we go, we have some reminders about ongoing work and upcoming events. So please join us again tomorrow at 5 p.m. to continue this conversation. We'll be joined by Dr. Lisa Puglisi, Jerry Smart, and Manya Harper-Harris, who are also community health workers at Transitions Clinic, to learn more about work in New Haven and how we can contribute as students and professional and prospective health professionals. Again, please consider signing our petition to expand the HSHM department to support more workshops and courses like this, and also sign our petition for the Yale School of Medicine to change their admissions requirements and curriculum to better ensure that physicians are trained to deal with disparities such as the ones that we covered today.
And lastly, I just want to give a big thank you to Tino, Professor Rich, and Dr. Wang for joining us today. And thank you all for participating, and we hope to see you tomorrow and at future events.